DIC, disseminated intravascular coagulation, has a very high mortality rate, high 90%. The reason is that all clotting factors are clotting up at the same time, known as a state of hypercoagulation. If multiple thrombi or clots isn't enough, it's followed by massive hemorrhaging. The clots turn into embolisms, a thrombus that is moving, and go to different organs in the body. With emboli hitting multiple organs, the organs get plugged up and fail from ischemia, or lack of blood flow. The next step occurs because all of the clotting factors are being used up, and eventually there are not enough clotting factors left to clot blood. At this point, it's kind of like having hemophilia all of a sudden, and a massive bleeding takes place because there's nothing to stop the bleeding. DIC can be caused from a lot of different things. Sepsis, or a really bad infection, is usually from bacteria, bacteremia, but some kinds of cancers, some solid tumors, some blood cancers, anesthesia, burns, major trauma, or just about anything that causes cell lysis and the release of tissue factor into the blood on a wide scale, and that's what starts the massive clotting throughout the body. A retained placenta is what we used in our in-class case study. Placental abruptions is when the placenta kind of just jerks right out of the endometrium before the baby's born, and that causes massive amounts of bleeding. Tissue factor is released, and the extrinsic coagulation pathway starts throughout the body because there's a direct blood link from the remaining placental parts. Signs and symptoms are bleeding and bruising because all of the blood clots everywhere. Hypotension is because blood pressure drops really fast because of massive internal bleeding. They say that with DIC patients can bleed from literally every pore in their body. So how would you test this? Prothrombin, PT, time, and partial thromboplastin time, PTT, are times on how fast someone is clotting. Also important to test for are the platelet count, fibrinogen, D-dimer, and fibrinogen/fibrin degradation products. When someone is bleeding massively and clotting up all of their organs, treatment is obviously a problem. On one hand, the patient desperately needs blood replacement. On the other hand, there are a lot of clots clogging up organs, so those clots have to be broken up. TPA activates plasminogen, and plasminogen produces plasmin. Then, plasmin can start to digest fibrin. This is called fibrinolysis. There are some anticoagulants, some natural and some man-made, that, quote, bust clots. Antithrombin 3 is made in the liver, and it'll deactivate thrombin before it can act on fibrinogen. Recall that fibrinogen had to be converted to fibrin. Without fibrinogen, fibrin can't form. Heparin is produced from basophils and mast cells, yes, from the immune system, and these also activate antithrombin 3. Warfarin, also known as Coumadin, blocks several different clotting factors, and you can see that on the next slide. You're not responsible to know this kind of detail for this class, but this is a good slide to show where the, quote, clot busters work to turn off the coagulation cascade. Warfarin, by the way, is also known as rat poison. This slide is talking about what I was trying to explain earlier. If you look at the top, the underlying disorder doesn't really matter that much, and it can be any disorder from that list on the previous slide. The important part is that the coagulation system is getting hyperactivated from massive release of tissue factor. Looking on the left side of the diagram where it says enhanced fibrin formation, that's where the clots are being formed. These thrombi, or microvascular thrombosis, are getting stuck in organs and killing them because of ischemia. On the right branch of this diagram, as all the platelets and clotting factors are being used up, massive bleeding begins. This is another diagram that shows the same thing that we've been discussing. Notice that the top level of the diagram has three separate general reasons why DIC, aka consumption, coagulopathy, can begin. This slide is the why patients get DIC in detail. DIC usually develops following endothelial damage and exposure to tissue factor, which complexes with tissue factor 7 and begins the extrinsic clotting cascade. The amount of thrombin produced during DIC greatly exceeds the body's natural ability to produce antithrombin. Obstructions of vascular flow that occur from circulatory deposition of thrombin causes widespread ischemia, infarction, and necrosis, accompanied by multi-system organ dysfunction. Of course, as widespread clotting occurs, clotting factors are consumed, and plasma produced by the clotting cascades begin to degrade fibrin before a stable clot can develop. Remember that tissue factor is not normally in contact with the blood. It's released in response to any kind of vascular injury to epithelium. Cytokines will also release it, and so will bacterial endotoxins. Please pause a minute and make sure you understand the sequence of events of DIC.